Welcome to the Mayo Clinic Ophthalmology Podcast, brought to you by Mayo Clinic. I'm your host, Dr. Andrea Tooley.
And I'm Dr. Eric Bothan. We're here to bring you the latest and greatest in ophthalmology, medicine, and more.
Today, we have the opportunity to sit down with Dr. Ray Iezzi, a vitreoretinal surgeon at the Mayo Clinic. He's going to enlighten us on the management of traumatized eyes.
Dr. Raymond Iezzi is a vitreoretinal surgeon here at Mayo Clinic. Dr. Iezzi's clinical interests include retinal degenerative disease as well as all aspects of vitreoretinal surgery, with a special interest in complex retinal detachment repair associated with diabetes, trauma, and proliferative vitreoretinopathy. He's also heavily involved in research, including retinal prosthesis development, nanoparticle-based drug delivery, and has been developing stem cells and retinal transplantation treatments for macular disease. He's a recipient of the Visionary Award from the Foundation Fighting Blindness, is a former HEED Fellow, NAP Fellow, was awarded the Ron Michaels Fellowship, and is a Fellow of the American Society of Retinal Specialists. Thank you so much for being here, Dr. Iezzi.
My pleasure.
We love talking about retina.
We do. Some. I think Pete's better, though.
Well, there is overlap.
Well, there might be some today. We're going to talk about your expertise in the care of patients after trauma. And certainly we all care for trauma, whether oculoplastics for Dr. Tooley, myself for peds, but and we put globes together and often send them to the retina specialist afterwards. So we're thankful you could be here to talk about this subject.
Oh, absolutely. It's a pleasure to be here. You know, my earliest exposure to the idea that there is something called an eye surgeon was my own family experience, where my father had an open globe injury and had to undergo subsequently several surgeries, including vitrectomy with prolonged face-down positioning due to gas placed in the eye. And I saw that he had to remain 2 months face down, and how emotionally challenging that was. And I subsequently developed several surgical approaches that mitigate the need for face down in macular hole repair and in many cases retina reattachment surgery. So it was actually very formative of my career, even to the present day. And I got very interested in highly complex ocular reconstruction and trauma and retinal detachment, largely due to that early interest.
You know, I don't think we knew that story about your dad having an open globe. That is so interesting. And I just want to shout out, we have another episode that we recorded with you, one of our first episodes actually, about face down positioning and your whole philosophy, which was extremely novel. And there's been a lot written about it. So we'll link that in the show notes, but it's another great episode if you want to learn about macular hole repair, face down positioning. But I don't think we knew kind of the impetus for this interest that you have. That's really special.
Yeah.
That's great.
Let's start off before we get to ruptured globes, because I think there's a lot to dig into there.
Mm-hmm.
Let's talk about just thinking for the comprehensive ophthalmologist listening, managing call or whether in their clinic or in an ER setting. Let's talk about non-penetrating injuries first. So blunt trauma, whether it's sport-related, a punch to the eye, whatever it might be, can have retinal sequelae. Share with us, as patients may or may not have vision affected acutely with whatever the posterior damage might be, but share with us remind us the common retinal diagnoses that might impact vision after blunt trauma.
Absolutely. Blunt trauma is one of those things where we have to think about the occult, particularly maybe even during Halloween, right? Mm-hmm. It's one of those things where, the patient may present with acute vision loss due to, let's say, an anterior chamber hemorrhage, like a hyphema. There may be a vitreous hemorrhage due to a traumatic tear in the retina or to a traumatic posterior hyaloid separation. In the setting of acute trauma, it's often difficult to look in the back of the eye, either because there's a corneal abrasion and the patient is very hard to examine, or the media are not that clear. And so I would say, in the early assessment of a patient who suffered blunt trauma, let's think about, what was the mechanism of that blunt trauma? Was it a high-speed, high-velocity projectile from, let's say, some form of gun that might have shot a plastic pellet, where there might be some associated contusion? Was it an accidental thumb to the eye, like a sports injury? Was it a low speed blow or high speed blow? And I think that we have to think about hemorrhage in association with other retinal complications. And so a dilated fundus examination is going to be very important. If that's not possible, getting at least a B-scan ultrasound to rule out something grossly abnormal about the back of the eye, and then referring, if the posterior seg dilated examination is not clear or is ambiguous or not possible, get that patient to a retina specialist quickly so that we can look for things that happen commonly. So typically, vitreous hemorrhage may or may not be associated with a peripheral retinal break. We want to figure that out early because we can treat those and mitigate the need for retina reattachment surgery later on. Patients can develop, if they're presenting later, they may have that break progress toward a regmatogenous retinal detachment. And sometimes that detachment is localized and can be treated with just a laser as opposed to bringing them to the OR. But more commonly, with the more impactful blunt traumas, patients can develop retinal dialyses, and they're very hard to pick up on because the dialysis occurs at the ora serrata. It's an avulsion of the retina from the RPE, and that typically requires a sclerobuckle. So we want to get to these patients sooner than later. Dilated fundus examination is the mainstay and minimum basic requirement of treatment. And if that can't be done, an ultrasound is an okay surrogate in selected cases to rule out gross disorganization inside the eye, but still doesn't replace a dilated exam. Dilated exam, because with an ultrasound you can't see a retinal break. You can't really identify a low-lying peripheral retinal detachment or a retinal dialysis because the ultrasound focuses too much posteriorly, and we're not getting those anterior structures.
One thing I remember so often seeing as a resident, seeing trauma, is commotio, or just retinal edema, kind of from blunt trauma, non-penetrating trauma. And as an oculoplastic surgeon, I see a lot of traumatic optic neuropathy from the optic nerve getting jostled, and the same intracranial component like concussion. I feel like those are all kind of in the same genre, just from this jostling type injury. But it seems like, at least with optic neuropathy, concussion, the avenue for recovery is a little smaller. We've looked at giving high-dose steroids and found that can actually have more intracranial risk. I still give steroids sometimes for traumatic optic neuropathy. Commotio seems like it has a little bit better outcome. Is that true, or is it still the same? Is there anything we can do to treat that?
We currently don't have any objective, well-studied methods for treating commotio. But one thing about trauma, which I think is pretty uniform, is that the visual outcome often relates to specifically what structures were damaged. So you could have somebody that has a penetrating injury and it might go right next to the center, but the center is preserved and they can still read the eye chart, no problem. So a lot of it is sort of like where the actual trauma had its end organ effect. And that's similar with commotio. There's concussion and then there's traumatic brain injury, right. Sort of a spectrum of commotio as well. Mm-hmm. And if the commotio is mild, the patient will have some visual recovery. I also hesitate to be definitive in prognosis early on. Yeah. Patients are tremendously emotionally affected by the potential loss of an eye. And usually if a retina specialist is gotten involved in the case, we explain that we're really trying to save the eye and that we're going to have to work longer and wait for the long-term prognosis, that we can't really predict what the vision's going to be like. And I think deferring any definitive statements on vision is important because we don't know what the patient's going to ultimately wind up with. And it is somewhat helpful to frame what we're doing in terms of, well, right now our goal is to save the eye. Mm-hmm. And it's really unclear what your vision's ultimately going to be like. But this was, let's say, a very serious injury, and it may affect your vision long term. I think setting a framework of expectation early on is important, but I always hesitate to give any definitive statements on outcome, unless, we're really trying to save a very end stage injury.
Makes sense.
You mentioned vitreous hemorrhage because it can obscure ability to adequately assess for commotio, for a ruptured choroidal status, or for retinal breaks. So for people, we have the luxury of being able to call a friend, our retina specialist, and promptly after non-traumatic or for blunt trauma without perforating or penetrating injury. For someone in a very rural setting or that maybe have intermittent retinal support, how often do you do a B scan? How quickly do you need to refer? Is there a realm that you can monitor some of these, obviously with maybe steroidal coverage and dilation, and just let the eye rest while you're ultrasounding that? But at what point what level is okay to monitor, and what level do you need to punt to make sure the retinal gets more formally evaluated?
Well, for some of these cases, that's a great question. I think for some of these cases, I would hope that a referral to Mayo Clinic would be the easy button, okay, where you can get your friendly neighborhood retina doctor to take a look. Because it does take time. Sometimes with vitreous hemorrhage, we have windows of opportunity in terms of getting a glimpse.
Or bilateral patch. I just listened to a lecture about bilateral patching. I'm a believer.
It is really a good tool.
It's such a good tool.
Really
it's so underrated.
It is. And in fact, we can reattach retinas by bilaterally patching. We can make retinal detachments much less than they were, reducing the amount of manipulation in the eye. So bilateral patching has a super huge role.
Okay, you need to explain that for listeners that don't know.
I'm such a fan. I'm going to give a shout out to Will Park, who just gave a lecture on bilateral patching. And Will is phenomenal, great retina specialist. We work with him a lot. But he made it out to be like this very novel technique. And I said, Will, we've been doing this in Mayo forever. Yeah. So you got to.
It probably emerged from the ancient Egyptians.
It's just resting eyes well.
The fact is that retinal detachments occur due to eye movement. Okay, so you get a break. It doesn't, generally speaking, your tear in the retina doesn't immediately associate with a retinal detachment. It takes an active pump to pump fluid into the subretinal space in order for that retina to come off. So the corollary to that is let's patch both eyes permanently, for a period of time. Patch both eyes completely so patient can't peek. The lack of eye movement, because patients don't typically move their head side to side like they do with their saccadic velocity. That lack of eye movement allows the retina pigment epithelial pump to remove a lot of that, in fact, sometimes all of the subretinal fluid, reattaching the retina. And so bilateral patching is, prospective evidence to show that it can diminish the extent of a retinal detachment and protect even the macula in, let's say, a macula on retinal detachment. So bilateral patching has a tremendous role in helping us manage retinal detachment preoperatively. Physicians and patients don't often like it because the physician is putting a patch on that's now mimicking this blind role. Patients can get a little freaked out by it. And so patients can sometimes, peek around them. Sometimes they peel a little away, and that kind of defeats the purpose. But I use bilateral patching not infrequently. But it also has a role in the management of intraocular hemorrhage, because if a patient has a diffuse vitreous hemorrhage, let's say they just came in from parking the car, they flop into your exam chair and you're looking at them, it's like a snow globe that's been shaken up, right? Where we've got hemorrhage everywhere. If we, patch them and let them sit quietly, a lot of that blood will settle down and I'll get a chance to look at the peripheral, at least the superior retina. And if we have a patient bilaterally patch and come in the next day, a lot of times I can even offer treatment through the peripheral retina because that blood will settle down so much that all of a sudden I'll be afforded a view of the periphery. So it can have diagnostic and in fact treatment implications. There are several cases where a patient came in with a hemorrhagic break. We knew it was a break. It was a very difficult view and we couldn't necessarily see well enough to treat. But by having them bilaterally patch and come back the next day, we take the patches off while they're at the laser, and we can actually get laser treatment in. And of course, as long as we can see the break and the retina is not terribly detached, we can even offer cryotherapy which goes in from the other side, which freezes through the sclera into the retina area. So bilateral patching gives us several treatment options.
Okay. So come in, hemorrhage is there, can't get a look, might patch overnight, reassess the next day.
Yep.
If they still are hemorrhagically difficult to examine, at what point do you get nervous that in comprehensive practice, you should refer after ultrasounding for how long?
Well, I wouldn't get nervous because there's no rule for that, really. Referring out for an ultrasound if you don't have one in the office is a great idea. I'd do it early. And ideally, you'd get somebody who's really skilled in ultrasound. We've got great technicians here. In fact, many times we wheel the portable ultrasound in our cells and do the ultrasound. There are two approaches to the ultrasound that are important, one being dynamic ultrasonography, where we actually have the patient move their eye. And many times a retinal detachment or a dialysis that appears flat on a stationary ultrasound will suddenly elevate and then reattach on a dynamic ultrasound. So it allows us to see even flap tears occasionally. If you know how to do dynamic ultrasound, if the vitreous is inserted into a tear, then you can actually see that whipping activity in the eye, and all of a sudden the flap will elevate and then like a trapdoor go back down. So it lets us understand, what is the mobility of the retina. In some cases, there's been a delayed presentation of the trauma. And if the retina is very, very mobile, then we know that there's not a tremendous amount of PVR. But if there is a retinal detachment and on dynamic ultrasound, the retina is quite fixed, that funnel detachment doesn't seem to be moving very much, then we know it's associated with PVR. Mm-hmm. It's a chronic condition, and that's not an acute emergency that we would bring to the OR immediately. So dynamic ultrasound gives us an awful lot of information, both with regard to vitreous hemorrhage, retinal break, and the extent to which that detachment's been there or not. Okay, sometimes patients come in with acute on chronic symptoms, meaning they've had a retinal detachment in the periphery, not been aware, and then they suddenly become aware of a chronic problem, or the retinal detachment progresses through the center, and they become acutely aware that they have a detached retina, but it's an acute on chronic progression. And ultrasound can be very helpful if there's a limited view. And of course, with our standardized ultrasounds, we do all the fields, and we look, obliquely and paracentrally, sagittally, to get a series of views that will help us determine what's going on. And the other thing that's really interesting is because retina doctors are faced often with limitations of view, we get pretty good at looking at through poor media. So we can often see the retina underneath that blood. And so just having an examiner look, sometimes it mitigates the need even for the ultrasound. One last thing I'd like to say about examining through vitreous hemorrhage is that our scanning laser methods, like the Optos or even a Heidelberg imager, even though we can't image peripherally with the Heidelberg, we can with the Optos. Those laser scanning techniques can get through blood tremendously well. You got to think of the indirect ophthalmoscope as sort of like a big flashlight in a fog in the setting of vitreous hemorrhage. We're using flood illumination from the video indirect to look. So what I would recommend is that the first thing you do is to make your illumination spot size as small as you can when you're looking through a hazy media, because it hones down and it reduces that headlight in the fog effect where you get whiteout. The scanning laser techniques, it's a single fine 100 micron or less laser beam that's being rastered across the entire fundus, and that doesn't light up the blood in any real way. And so these scanning laser techniques are far superior than most indirect ophthalmoscopic exams or fundus cameras because we can see through blood. So if somebody has an Optos, that's the way to go. Even in the setting of a vitreous hemorrhage, if they look in and can't see, the Optos can often get through that.
I love that. That's such a great tip. Let's move to surgical treatment after the exam. Let's say it wasn't blunt injury. We've got an open globe situation. We've repaired the globe. What are the times where then retina gets involved? Either there's been uvea involved in the globe injury, or they progress to get an RD or PVR or something like that. Like when do we loop retina in after globe closure?
Yeah, that's a great question. So as a retina specialist, I always like to hear about what's going on. If I know that there's an open globe, then I know that it's going to ultimately find its way to the retina service, and we'll be better equipped to handle it and schedule it and all that. There are several philosophies, and most centers focus on the second philosophy. The first philosophy would be the patient has an acute injury. There's a vitreous hemorrhage. We're going to go in early and take care of everything at the same time. That's a little bit of a naive approach. It sometimes has a role. Certainly in the setting of an intraocular foreign body, it has a role. So there's a penetrating injury of the eye with a retained intraocular foreign body. Retina is usually going to get involved in that very early. And in the case of a perforation of the globe where an object goes in and goes out the other end, we typically like to wait because during vitreoretinal surgery, we're using an infusion line, and the infusion line needs to keep the eye inflated. But if there's a hole behind the eye, then we're going to wind up infusing the orbit and wind up with hydrated tissues and all of that. So it becomes a big challenge, particularly if we can't get back to that exit site if it's so posterior. So there's a benefit in waiting to do the vitreoretinal procedure because we can't keep the eye inflated in the way that we would want. And the concept of hemorrhage is more likely because the eye is inflamed usually. By waiting, we get the eye to quiet down, the tissues to become less inflamed, less choroidal dilatation, less chances of choroidal hemorrhage. So oftentimes we defer any intraocular procedure from a VR perspective to at least a week to 2 weeks after the trauma to allow the posterior hyaloid to spontaneously loosen itself up and possibly separate, and to allow those wounds to become more watertight just in the process of healing.
Yeah. That all makes sense.
So when you see a retinal detachment and they're repaired, and so it's maybe, let me back up and ask a question. So sclera's repaired, whether, let's say, before you see a break or before you see a detachment, whether you repaired everything, but it's been UV has been exposed, you tuck things in, or you had to trim some vitreous if you needed to. And there's, the ultrasound that shows hemorrhage, but things are attached. What's your normal time frame as evaluating that patient? As you said, you might wait for a season before letting things settle down and heal up, or let the wall have more integrity. When do you get involved? Because right now we punt them to you right away. But tell us the world of day 1 week, 2 weeks. How often are you seeing them? How often are you doing B scans as you're preparing for some sort of intervention?
Sure. Great question. That decision, the decision to do a vitreoretinal procedure is informed by, what does the cornea look like? Does the cornea have a big abrasion? Is there damage to the cornea that we need to heal so that when we go in, we can actually see what we're doing? An assessment of the lens. Is the lens, dislocated? Is it a patient that was pseudophakic that has a dislocated intraocular lens? Is the iris damaged? Is there a ciliary body cleft? So these all factor into the timing of the surgical procedure and the planning of the actual operation. Barring something that would cause us to go in sooner, we do like to wait for structures to heal. We do like to reduce intraocular inflammation with topicals and possibly even systemics, non-steroidals, or actually, what I mean is steroidal, not non-steroidal treatments. But we typically give topical steroids, maybe even systemic steroids, and wait for the eye to quiet down before we go in. We assess the choroid, the retina, and ciliary body, which is, by the way, the most important structure in determining if an eye is going to survive any of these procedures. The ciliary body is by far the most important anatomical structure, because if the ciliary body is damaged or lost, we have no way of keeping the eye inflated. So hypotony is related to damage to the ciliary body. And that's probably the most important prognostic thing. We could reattach a retina, all that, but if the ciliary body isn't pumping, we're going to have trouble keeping that eye from developing hypotony and eventual ptysis. So that's an interesting fact.
I wouldn't have guessed that.
Yeah.
It makes sense what you're saying.
So that's why we wait. We typically like to put the eye into the right place to undergo then surgery.
how quickly do you see PVR happen prior to your first intervention, or, I mean, in longer term follow-up concerns after your reattachment?
It's like that's the most dreaded complication and your expertise.
Yeah. PVR doesn't form immediately. There are low grades of PVR that are associated with intraocular inflammation that may present early on. Certainly, a retinal break, intraocular hemorrhage, and a retinal detachment are three things that contribute to PVR risk. If the patient is a smoker, they have a much higher PVR risk as well. And if their retina is detached chronically, if let's say the retina was detached and it was not noticed, so if there was an occult retinal dialysis or detachment anteriorly that someone didn't see, a late repair, late reattachment is associated with PVR. So that's why getting your friendly local retina doctor involved early is good. And then, of course, there's several principles of surgery that we use to try to minimize PVR, treat it a priori. It may be at an earlier stage, or we know that the patient is at a very high risk. So, for example, if I have a patient with a complex retinal detachment, let's say it was a blunt injury and there was an open globe as a result of a equatorial blowout of the eye wall under a rectus muscle, let's say, and the vitreous started to extrude from the eye like a tube of toothpaste, and the vitreous base was taken with it. What we'll see there on the ultrasound or on the exam is a closed funnel detachment with the retina closed and inserted, the oris serrata inserted into the exit site, into that open globe site. And that closed funnel will go right to the nerve, okay? So those patients can have remarkable outcomes, remarkably good outcomes. However, they're extremely high risk for PVR, especially in the macula. So we're talking about those patients, if we have a closed funnel detachment due to like one of those extrusion injuries, we can get them to read small letters on the eye chart and have great visual field. But what we see late is contracted PVR, usually in the posterior pole, that causes rotation of the retina and often central peripheral rivalry diplopia or even strabismic diplopia because the whole retina has been dragged down so much that it simulates a muscle imbalance, and their CPR is central and peripheral displacement diplopia from the retina alone. So oftentimes we'll use methotrexate. My mentor, Dean Elliott at Mass Eye and Ear, he popularized the use, discovered that it was highly relevant. It was actually first used and discovered here at Mayo with Dr. Polito and Dr. Bakri, where they identified that injecting methotrexate into silicone oil was in fact safe. And my colleague Dean, who actually trained me, he identified that weekly injections over a several week period, over a total of 13 injections, can greatly reduce the chances of PVR. And so if I'm dealing with a young patient that has a high risk of PVR, we may start methotrexate injections into silicone oil on the table at the time of the primary repair, and then weekly for 13 additional injections. So they're weekly for 8, and then 4 additional that are every 2 weeks toward the end.
Wow.
And we can really greatly reduce PVR and increase outcomes.
That's a big commitment, though, from the patients.
It is. It's particularly challenging for patients who come from the Dakotas, let's say. But fortunately, we've got colleagues out there that can do the injections for us. So if I'm referred in a case from, let's say, Eau Claire or elsewhere, retina providers there can do those intravitreous injections, and I can follow the patients up periodically to see how they're doing.
That's terrific that you said they can have really good outcomes, better than you'd think. On my side as an oculoplastic surgeon, I get people sent to me for an enucleation consult or an IVIS consult that have been told, there's nothing else, there's nothing we can do. You had an injury, the retina's toast, And sometimes they haven't seen they haven't seen our retina here, and I'm not going to make that call. And the patients are always saying, isn't there anything else you can do? How do you know when it's end of the road versus we could reattach this and maybe you could get some vision?
I think really the only way to know that is to send it to a retina doctor that specializes in complex, repairs. It is interesting that there's a heterogeneity of training and experience, and depending on who you see, you're going to get different answers. So a doctor that, let's say, operates in an ambulatory surgery center may not be able to schedule a 4 or 5 hour case. Whereas at Mayo, we routinely do these kinds of things. So the center that you go to, the actual surgeon and their operating room capabilities, that matters. But it's always best to go to somebody who would be considered the end of the road, to definitively help that patient in that process of understanding what the chances are that surgery could do something good for them, whether it's retina reattachment or enucleation and evisceration. But when I was a fellow, I was taught that there's no retina that we can't reattach. And that was the premise that I spent most of my career on. It's very rare that we wouldn't go in and do something heroic to try to save an eye, because we look at all vision as important. So yeah, we if, however, the eye is in ptysis, if the cornea is has band keratopathy and the eye is shrunken, where you see limbal folds, full thickness scleral folds, those are ptysical eyes, and we don't operate on those. We don't operate on patients with cystic retinal detachments, where the retina on ultrasound has cysts, because we know that the integrity of the neural tissue of the retina is gone. And when we get in there, we see that we have no seeing retina. And of course, we use a transilluminator system, not an indirect, to assess light perception and projection. So we really take it very seriously, assessing their vision function. As I do an ultrasound biomicroscopy study, which we have here, where I can look at the integrity of the ciliary body. I look for blunting of the ciliary processes to determine if that ciliary body is capable of producing aqueous. So that impacts my assessment of prognosis in a big way. If the ciliary processes look healthy, that greatly increases the chances I'm going to intervene surgically to try to help that eye.
So certainly there are eyes based on all of these expertise, imaging and exam techniques that you can say this eye has hope. There are going to be eyes that fairly clearly early on don't have hope, whether the optic nerve has been avulsed, whether or not. But in ruptured globe situations, my memory is that a discussion of sympathetic ophthalmia should take place in eyes that don't have hope. What is the current timing for that discussion, and is that still something that's included in the discussion with the patient in those initial weeks after repair?
That's a great question. Sympathetic ophthalmia is something that is chronically managed. Okay, so it's not simply a matter of taking an eye out that doesn't look so good. Sometimes we'll do a heroic procedure, save an eye, and the patient could develop sympathetic ophthalmia in the fellow eye with or without an enucleation. So the evaluation and treatment of sympathetic ophthalmia is a lifelong thing. And I think it's important to introduce the concept early on that, our goal here is to save this right eye, let's say, and we're gonna continue to monitor that left eye to make sure that it's healthy and can see long term. And we're gonna recommend polycarbonate lenses, and we're gonna examine you periodically to make sure that the eye isn't undergoing inflammation as a result of the other eye's injury. And that's treatable. We can treat that with systemic medications and try to mitigate any vision loss that could be associated. So we do heroic procedures when it makes sense. We save vision when we can, and we remove eyes when we can't do we can't reverse it. And we continue to follow the fellow eye for signs of sympathetic.
That's perfect. Well, fantastic overview. That was just great. I learned so much. I think this would be very helpful. Hopefully no one has to deal with any terrible trauma, but maybe this can help some physicians along the way. So thank you, Ray.
And I'll add one more plug. As the pediatric ophthalmologist dealing with unilateral amblyopia in kids, certainly remember to protect.
Yes,
wear protective glasses after monocular injuries of all ages. So thank you again for sharing this time with us.
Absolutely. My pleasure.
You can find all episodes of the Mayo Clinic Ophthalmology Podcast on our website.
Thank you for listening, and we definitely look forward to sharing more